Hello guys, Tony here. Welcome back to the channel. Quick update on myself. I've started my second year of medicine at the Royal Melbourne Hospital Clinical School about 2 months ago. And I've been having a lot of fun and I'm learning a lot. I was planning on making a video about my experience, but obviously with the recent COVID-19 situation, that has been put on pause. Now, I'm not going to comment much on the virus as I'm not an expert, but I would like to remind everyone to try and stay indoors when possible, practice good hand hygiene, and above all else, look after yourself and each other. Now, at the request of my peer tutoring group, I'm going to be covering some of the basics of the electrocardiogram, or ECG. Please comment down below to let me know if I've made any mistakes or if you're unsure about anything. I've also attached a document in the description with some of the diagrams that I'll be going through the video.
So what is an ECG? An ECG lead is a graphical representation of the electrical activity of the heart, and it is obtained by analyzing several electrodes. Now, the standard ECG that we use is a 12-lead ECG, and that's obtained by using 10 electrodes. And these 12 leads consists of 2 sets of ECG leads. You have your limb leads and your chest leads. And sometimes the chest leads are also referred to as the precordial leads. Now, at any given instant during the cardiac cycle, all ECG leads analyze the same electrical events, but from different angles. And that's a point that we'll go over very soon. And remember, it's not always necessary to examine all 12 leads in every situation. For example, for diagnosis of some arrhythmias, you do not need to look at all 12 leads. Now, your 10 electrodes are divided into exploring and reference electrodes. Just remember, exploring electrodes are positive and reference electrodes are negative, right? And how your leads are obtained. Your leads are made up of one exploring, so one positive electrode, and one or more reference electrodes, one or more negative electrodes. And remember that a vector that's heading towards the exploring electrode will give you a positive wave or deflection on your ECG. And I'll go through an example for you so this will all make sense in a second. Okay, so here we have a person. Not a very good drawing, but here's a person. And they have got 4 electrodes on their body. Left arm, left leg, and right leg. Out of these 4 electrodes, we only need to care about these 3. The right leg is the ground electrode, so it doesn't contribute much to the ECG. Now, when you have 2 electrodes, remember how I was talking about exploring and reference electrodes? Well, the lead that is formed by the 2 electrodes, it always travels from the reference towards the exploring. So for example, if in this case, the left arm is the exploring electrode, it's positive, and the right arm is negative, so it's reference electrode, then the lead that you obtain will be traveling in this direction, right? And this is lead 1. Similarly, with your left leg, if the left leg is positive, so if the left leg is an exploring electrode and the right arm is negative, once again, you have a lead that travels in this direction. Yeah, and that's lead 2. And lead 3 travels in this direction. So in this case, your left arm will be the reference electrode and your left leg would be the exploring electrode. Now, you might be asking yourself, what is the point of having all these leads? Well, we're talking about the limb leads right now. So leads 1, 2, and 3, they are 3 of the 6 limb leads. And the limb leads are excellent at looking at the heart in a frontal view. So in a coronal slice of the heart, the limb leads are great. And the different leads that we have can actually help us locate the site of pathology. What do I mean by that? Let's look at lead 1. Yeah? Lead 1 views the electrical activity of the heart in this direction. So this one. And if we see there is something wrong with the ECG reading of lead 1, then we know that there is going to be some kind of pathology on the lateral side of the heart. Similarly, if there is something wrong with the ECG reading of lead 2, then we know that the inferior portion of the heart is experiencing some kind of pathology. When we represent these leads in a hexaxial reference system, it looks somewhat like this. So lead 1 is at 0 degrees, it's horizontal. Lead 2 is at 60 degrees, and lead 3 is at 120 degrees. Now, it's, very cool to have, lead 1, 2, and 3, but if we want to be able to localize the site of pathology even better, it's obviously better to have more leads. And that's where the other 3 limb leads come in. Recall how leads 1, 2, and 3 are obtained by using 2 electrodes each. Now, these 3 are the only leads that uses 2 electrodes. All the other leads in the body uses 3 or more electrodes. How does that work? Well, for example, if we set the right arm as the positive, so exploring electrode, and the left arm and the left leg both as reference, so negative electrodes, what's going to happen is, think back to your high school math days, there's going to be a vector sum. Yeah, so there's going to be a vector that goes this way, and then another vector that goes this way. Now, these 2 vectors, they're going to cancel out. So all that's left is this vector. So ultimately, in the end, what you're going to have is a vector sum that travels this way. Right, and we call this AVR, R for right. Similarly, you can obtain AVL, so L for left, by making this the exploring electrode and these 2 the reference electrodes. So what you're going to get is a vector going this way, and that's your AVL. Finally, your AVF, F for foot, goes down this way. So in this case, this is the exploring electrodes, and these 2 are the reference electrodes. And by having these 3 extra leads, it helps us to fill out this hexaxial reference system in a lot more detail. So this one will be my AVF, and then, so this will be at 90 degrees. My AVR is going in this direction, which isn't very useful because, I've still got a gap here. So what I do is I flip it around and I look at the negative AVR. And this is going to be 30 degrees. Now, on most ECGs, the lead AVR is actually represented as its positive form. So you may notice that the QRS complex is upside down. On some ECGs, you can actually change the setting to make it represent negative AVR only, which, is more useful. But that's beyond the scope of this course. And your AVL goes this way. So AVL, and that's going to be minus 30 degrees. So here are the 6 limb leads that we have, and we can divide those 6 limb leads into two categories. We have these three, so lead 2, AVF, and 3. We call them the inferior leads because they allow us to look at the inferior portion of the heart. And these three, AVL, lead 1, and negative AVR, we call them the lateral leads because they allow us to look at the lateral portion of the heart. So with the limb leads, we are able to look at the heart in a coronal or frontal view, which is great, but the heart is not a 2D structure, it's a 3D structure. So in order to see the heart in a horizontal view, so like a straight slice into the heart type of view, we will need the chest or the precordial leads. Now, same as the limb leads, there are 6 precordial leads, and the exploring electrodes for the chest leads are V1, which is found to the left of, to the right of your sternum in the 4th intercostal space. Your V2, which is found to the left of your sternum in your 4th intercostal space. You have your V4, which is in the mid-clavicular line of your 5th intercostal space. Your V3, which is just between the two, between V2 and V4. V5, which is found in the anterior axillary line, same as V4 in the 5th intercostal space, and V6, which is in the mid-axillary line of the 5th intercostal space. So I'll also put it onto this top-down view of your chest. So V1 would be here, V2 would be here, V3 is somewhere here, V4 is here, V5 is here, and V6 is here. Now, remember how I was talking about, in order to have a lead, you got to have at least one exploring electrode and one reference electrode. Well, where is the reference electrode in this case? It's at this point. It's called Wilson's central terminal. Now, this point, Wilson's central terminal, it's not a real electrode. It's a theoretical electrode because obviously you can't put an electrode inside someone's chest. That wouldn't be very feasible. Remember, ECG is a test that we do for pretty much any patient with any cardiac issues. So having to put an electrode into all of those patients' chest is just not feasible at all. So how do you derive Wilson's central terminal? Well, it turns out that you can easily find it at the center point, or right here, the convergence point of your original 3 limb electrodes. And this triangle that's formed is called Einthoven's triangle. You don't really need to know. And the center point is Wilson's central terminal. So all you need to know that is for your precordial chest leads, your reference electrode is a theoretical electrode found somewhere in your thorax. And by having this reference electrodes, it allows us to view the heart in many different angles on this horizontal or transverse plane. And this allows us to see the heart not only in this top-down 2-dimensional view, but also this transverse slice. So by combining the two, essentially we are able to see the heart in a 3D view, which is great. Now, just a bit of nomenclature stuff. V1 and V2, they are called your septal leads yeah, which allows you to see the septum of the heart. V3 and V4 are your anterior leads, and they allow you to see the anterior portion of the heart. And V5 and V6 are your anterolateral leads, and they allow you to see the heart in this anterolateral direction. I've attached a really good image that kind of summarizes what each of the leads do and what part of the heart they show. So give that a look. It's in the description. I would just like to quickly point out that the 12-lead ECG system we're talking about today is mainly used for detecting abnormalities in the left ventricle, although certain leads such as V1 and V2 can occasionally pick up ECG changes originating from the right ventricle. None of the leads in the 12-lead ECG system are adequate enough to detect vectors of the right ventricle. So if you want to look at the electrical changes in the right ventricle, you should use a different ECG system, which we won't go into today. We have covered the leads of the ECG. Now let's go on to how to actually read an ECG. Now, I'm sure a lot of you will be familiar with this graph, which is the ECG tracing of a cardiac cycle. I remember when I was in first year, I really struggled with understanding and memorizing this graph. But I've learned over the years that if you understand two things, then this becomes really easy. All right, the first thing you got to understand is how the cardiac conduction system works. And hopefully you would have done this in undergrad. The other important thing, and this is really, really important, you got to understand that any depolarization that follows the direction of a lead, that is, any depolarization that goes from a negative electrode towards a positive electrode, will result in an upward deflection on the ECG. Okay, let's quickly revise the cardiac conduction system. Your electrical signal starts at the SA node. It fires towards your AV node and then goes into your AV bundle of His, splits into the right and left bundle branches, and then goes up in your Purkinje fiber system. All right, now let's apply this onto this. The first wave that you see here is the P wave, and the P wave represents atrial depolarization. How does this work? Well, looking at this, when the electrical signal travels from your SA node to your AV node, that results in the depolarization of your atrium. And since it's traveling in the same direction as lead 2, this is an upward deflection. Your PR interval, which is this bit here, represents the delay at your AV node. Now, AV node is kind of like a gatekeeper. It slows down conduction. So since the conduction is slowed, it results in no upward or downward deflection. The PR interval is actually quite useful in ECG readings because it serves as what we call an isoelectric or reference line, which will become apparent later. Next is the QRS complex. The QRS complex represents ventricular depolarization. Now, when I was the first year, I struggled to understand why the Q wave goes down. I could easily understand why the R wave goes up because, as your ventricular depolarizes, it's in the same direction as your lead 2, so obviously it's going to go up. And once it moves into Purkinje fibers that goes in the opposite direction of lead 2, this way, it makes sense that the S wave would go down. But why does the Q wave go down? Well, what the Q wave represents is actually septal depolarization. That is the depolarization of your septum. So if you think of this as the septum, and this is lead 2, the way that your septum depolarizes is actually from the left side towards the right side, like this. And once again, going back to our high school math, this results in two different vectors. It results in a vector that is perpendicular to your lead 2. And if it's perpendicular to your lead 2, it's not going to result in any deflections at all. but it also results in a vector in this direction, which is opposite to the direction of lead 2. And hence, your Q wave, which represents septal depolarization, goes down. So now we've covered the QRS complex. Let's move on. Right here is the J point. The J point marks the end of your QRS complex as well as the start of your ST segment. Its significance will become apparent when we talk about STEMIs later. All right, so your ST segment marks a point where your entire ventricular myocardium is already depolarized and it's waiting to be repolarized, but in the meantime, it's not doing anything. And that's why it's flat. Your T wave represents the repolarization of your ventricles. And, it goes in this direction, but since it's repolarization, which is the opposite of depolarization, it's like negative times negative, right? So the two cancels out. So it becomes a positive deflection. And that's a quick rundown of a normal ECG tracing of a cardiac cycle. All right, so now we've gone through the ECG of a normal cardiac cycle. Let's try and read the rhythm strip together. So when you get a rhythm strip like this at the hospital, the first thing you want to do is always check the name and ID of the patient. This is very important. You want to make sure that you're reading the ECG of the correct patient. The second thing you do is turn your attention towards here where it says 25 millimeters per second. Now that's the normal rate at which an ECG is written. Just make sure it's in 25 millimeters per second. And then the next thing you want to do is you want to find out what's the heart rate of the patient. And to do that, you count the number of red boxes, so big red boxes, between two RR intervals. So between an RR interval, obviously, is one complete cardiac cycle. Yeah, so we count the number of red boxes. It's about 5. And what you do is you take 300. There's some conversion for this. You can look up the math yourself later. But essentially, you use 300 and you divide by the number of red boxes. And in this case, it's about 5. And you get the heart rate, which is about 60. Let's check. Heart rate 62. Yep, so that's correct. A heart rate of 62, that's pretty normal. The normal heart rate is 60 to 100. So we're not too concerned about this. Next thing we want to check is rhythm. Now, rhythm is looking at how regular the heart is beating. So what we do is we can look at the number of big red boxes between the RR intervals and see if it's fairly regular across the board. Yep, looks fine to me. What you can do on the ward is you can take a piece of paper and then mark 2 lines on the paper right where the QRS complexes are, and you move the piece of paper along, and if the 2 lines that you've drawn matches up with all the QRS as you move it along, then it's fairly regular. So we've determined that, yep, this guy has pretty regular rhythm, and it says here normal sinus rhythm, which means yes, it's regular. The next thing that we can do is we can determine the cardiac axis. Now, you really don't need to know anything about this. Just know that the hexaxial reference system that we talked about earlier is actually quite important for this. And sometimes you may hear the word normal axis or left axis deviation or right axis deviation, but you don't need to know what it means for now. Next thing you do is you look at the P waves. With the P waves, you want to make sure that, firstly, that there are P waves, and the second thing you want to make sure is that there is a P wave before every QRS. So we can look at here, yep, there's a P wave before the QRS, P wave before QRS, P wave, remember this is inverted, AVR is inverted, remember? Yep, there's one before QRS, this is fine. So after you've looked at the P waves, you can look at the PR interval. So not the PR segment like I said earlier, like I screwed up earlier, but right here we're looking at the PR interval. And the correct length of the PR interval should be 0.12 to 0.2 seconds. So the PR interval should be from here to here. And we can look here,
0.12 to 0.2 second. That means between 3 to 5 small boxes. Yep, that looks about right. So the PR interval is normal on this person. Now, if the PR interval is prolonged, that can mean some kind of AV heart block. You might hear first degree, second degree heart block at some stage in your learning. That's what it's referring to. And if this interval is shortened, you may have an accessory pathway, delta wave. You might hear, Wolff-Parkinson-White syndrome, but that's too complicated for now. Now, the next thing you want to look at is the QRS complexes. Now, QRS represents ventricular depolarization, and it should be fairly rapid. So it should be ideally less than 3 small boxes. If it's narrow, it's not a bad thing. But if it's broad, that's bad, and it can mean some kind of abnormal depolarization sequence. Next thing we want to look at is the ST and the T waves. Now, this is quite important, so pay attention. ST elevation is significant when it is more than 1 millimeters in 2 or more contiguous limb leads, or more than 2 millimeters in 2 or more chest leads. Now, what does that mean? What does contiguous mean? Contiguous means the limb leads are anatomically close to each other. So, for example, lead 1 and 2, they're not contiguous, because if you recall from what we discussed earlier, lead 1 looks at the heart on the lateral side, whereas lead 2 looks at the heart on the inferior side. So they're not contiguous with each other. But lead 2 and AVF would be contiguous because they both look at the inferior portion of the heart. And how can you tell if something has ST elevation? We'll go into that into a second. Now, ST elevation is most commonly caused by acute full thickness MI. And ST depression can also mean myocardial ischemia, but you don't need to know that for now. T waves, the only thing you need to kind of concern yourself with is T wave inversion, which is normal in V1. It can sometimes happen in lead 3. If it's inverted anywhere else, it's quite non-specific, but it means you're not well. You might have ischemia or bundle branch block or left ventricular hypertrophy. And if your T wave is very tall, that means you have hyperkalemia. And how I remember that is tau 10 T waves. Alright guys, so ST elevation is one of the few ECG findings that you need to know for first year med. And it is quite important. So how do you, how can you tell if something is ST elevation? Well, contrary to the name, you don't actually look at the ST segment per se. You look for the J point. Now, if you remember from earlier when I mentioned the J point marks the end of your QRS complex and the start of your ST segment. And what we're going to do with this J point is we're going to compare the height of the J point to our PR segment, which, if you remember, I mentioned earlier that the PR segment is our reference or our isoelectric line. So for this example, the PR segment and the J point are on the same level. So you do not have ST elevation. But right here, your PR segment is here, but your J point is a good 2 millimeters above it. Therefore, you have ST elevation in this case. Looking here, here's your PR segment, here is your J point. Once again, it's a bit less than 2 millimeters above. But if this was, say, a limb lead, then we would be concerned with an ST elevation, provided there are 2 contiguous limb leads showing the same thing. Here, you do not have ST elevation. In fact, you have ST depression, because if you look here, here's the PR segment, here's your J point, ST depression. This is a bit too complicated, but all you need to know is if the J point is here and the PR segment is here, then this is ST elevation. Now, let's go through an example of a STEMI. Now, if you remember from your lectures, for acute coronary syndrome, you can have stable angina, unstable angina, STEMI, and NSTEMI. So NSTEMI is kind of the intermediate stage of your acute coronary syndrome,
whereas STEMI is like the end point. That STEMI occurs when you have transmural infarct. So this is your classical heart attack, and it's quite bad. It causes significant ischemia and necrosis of your myocardial tissue. So how do we look for it? Let's just skip all the rate and rhythm stuff and go straight to the money. We're looking for ST elevations. So for example, if you look here in lead 1, you can tell here is the PR segment, and here is your J point. You see like this distinct notch here, that's your J point. So that's about 1 millimeter above your PR segment. Let's see if we can find another one. In lead 2, no such thing. They're on the same level, pretty much. J point and PR segment, same level. Not very helpful. Here, once again, no, not super helpful. Not super helpful. AVL, see right here? Here is your PR segment, and here is your J point. Once again, it's elevated by about 1 millimeter. And if you recall, your AVL and your lead 1, they are in fact contiguous. They both show the lateral side of your heart. So that's already, sign of a STEMI. Now let's go to the precordial leads. In lead 1, you have lead 1. V1 is not the best one to look at. How about V2? See, there's a very significant ST elevation. Here is your J point, and then here is your PR segment. That's a good 3 millimeters above. And then right here, once again, you have your QRS. Here is your J point. Here is your PR. That's about a good 3 millimeters above as well. Now, don't be fooled by the tall T waves. A lot of people mistake ST elevation with a tall T wave. A tall T wave doesn't necessarily mean ST elevation. So don't be confused by that. And let's look over here. Once again, PR segment is over here. Your J point is elevated, so another sign of ST elevation. Here, pretty minor, not really. Your PR segment is here. It's elevated by about 1 millimeter. So nothing too worrying, but essentially we're concerned about V2, V3, and V4. And if you kind of think back to what I mentioned earlier, V2 is a septal lead, so it implies some kind of septal damage, and V3 and V4 are the anterior leads. So this is what we call an anteroseptal infarct. And if you can link this to your anatomy knowledge, remember how your coronary vessels are responsible for perfusing different parts of your heart. Well, it turns out that your left anterior descending artery, so your LAD, is responsible for supplying your septum as well as your anterior left ventricular wall. So maybe there's some kind of LAD infarction or defect here.
Anyways, that was an intro into the basics of ECG. If you found that helpful, make sure to leave a like, comment, and subscribe. And if you have any questions, make sure to drop them in the comment section below. As I mentioned before, I've attached a document with some of the diagrams I showed in this video in the description, so go and check that out. And other than that, look after yourselves, look after each other, and I'll see you guys in the next video. Hey guys, a bit of behind the scene content on how this video is made. As you can see, it's got a very good setup here. Yep, nice.